So we are at noon and we have a very packed agenda today. So I'm going to go ahead and get us started. I really appreciate everybody being here for today's Family Advisory Council meeting. This is a quarterly opportunity for families to hear directly from the department about some of our initiatives and what we're working on, but it's also a really important opportunity to hear for all of us to hear from you. So thank you very much again for joining us. If you have not used Teams before, this is a little bit of a guideline of how you can use your video off and on, as well as mute and unmute yourself. We do ask you that you make sure you're muted if you're not speaking, so we can have a good call quality for everybody. We do encourage you to use the video feature if you'd like. We'd love to see your face. And I'll also share that today's meeting is being recorded, and we will have this posted on our Family Advisory Council webpage of the DODD website in a couple of weeks here. So we do appreciate everybody coming. We are going to start today with an opportunity to interact with Director Hauk from the department with our DODD leadership. We are going to go into a presentation about behavioral support, and then we'll have some updates about things happening throughout Ohio, as well as here within the department with Ohio Rise, our adult day services, what's happening with the Ohio ISP, update from our Medicaid division, as well as some updates from the family work happening here as well. So we really look forward to this time together. We're going to start with our time with Director Hauk, who has joined us today. We're really excited that she is here. One thing that I'll share is this time together with DODD leadership is really an opportunity for us to hear firsthand information from a whole lot of different people about different issues that are affecting multiple folks in Ohio. And we really want to give everybody an opportunity, a chance to share. So I will say, if you do have any particular concerns about specific situations or services that you're having, I'll be happy to connect with you personally, and we can see what we can do to support you in that regards. So with that said, Director Hauk, I'm really excited that you're here with us today. Thank you very much for joining us.
Hi, everyone. Sorry, I don't have my camera on. I'm actually driving. I'm out in Paulding and Van Wert today visiting. So, but I did want to jump on the beginning of the call and see how everyone's doing, and if there are things specifically that you wanted to chat about.
So with that said, we do have a chat feature. If you wanted to put something in the chat, I'm happy to read those. If you have anything that you want to share or what you're experiencing or hearing from families throughout Ohio, I look forward to hearing from you now. So Rhonda, I see you have raised your hand. How are you?
I'm okay. How are you?
I'm well, thank you. Thanks for being here today.
I just have a brief comment and concerns. We appreciate the work of other families before us, Ohio Family to Family, doctors, and the improvements made to DODD. We have additional concerns to share that affect those with Asperger's. The ADA ensured those with disabilities could access the necessary accommodations for school, work, and the community. The CDC recommends ABA therapy, positive reinforcement accommodations throughout the lifespan in school, community, and work for those with Asperger's, which has been included in ISP transition plans and OCALI training. Businesses with Asperger hiring programs employ trained job coaches providing support with accommodations that include positive reinforcement. Many businesses such as Amazon or agencies such as Ohio BWC also implement positive reinforcement programs for those non-disabled peers. The Knox County Board continues to claim that it's illegal for them to implement ABA therapy positive reinforcements as required for well-being and success, even though resources have been approved by a hearing officer. According to NIH, ASD burnout is due to lack of support with accommodations with negative impacts on their health, capacity for independent living, and quality of life, including suicidal behavior. The Knox County Board has not implemented the necessary support with accommodations, including ABA therapy, positive reinforcement as required leading to a failed outcome of ASD burnout, according to their own trauma consultant. Those with Asperger's need a case manager trained in Asperger's to ensure necessary and appropriate support with accommodations, including ABA therapy. Positive reinforcements are available, effective, and implemented as required for well-being and success for supported living and working in the community. Can the advisory board provide assistance regarding these necessary support with accommodations? We've never heard of ABA therapy as illegal. And we're just at a loss.
So yeah, I'm not familiar with that particular. I don't know if Director Hal has any comments, but I'm happy to connect you with some of our folks here within the department who may be able to provide some assistance. I see Matt is here with us. Matt, did you have a comment you would like to share? Matt is
Yeah,
from within the department.
I can
Can
try
you
and
introduce
weigh in on
yourself
that
for us, Matt?
question.
If
Hey,
you hit
I'm Matt
dismiss,
Bedlinka.
does that exit you out, or do you have to sign out somewhere? Dismiss up in the upper right-hand corner. Because I was going to exit her out of her, and I was just going to get on my.
Okay.
Go ahead, Matt.
I'm Matt Bedlinka. I'm a cross systems regional liaison with the department. And I think it's a great question about ABA. And there's certainly ABA therapy is certainly really helpful for a lot of people. But there are some concerns. I think that some of the interventions there might be restrictions. Without knowing the specifics about the individual that you were talking about, I think it would probably help to loop in somebody from your region, whether that's one of my coworkers or a community resource coordinator, to look at those specific interventions.
Well, I guess in this case, it's life-saving. So I don't know how it's restrictive when it saves lives. I mean, it ensures well-being, it ensures success, it saves lives. So we're at a loss.
Yeah, and certainly nothing in any of our rules or in the behavior support rule, it would be in place to prohibit someone from doing a life-saving measure or something that's needed to keep somebody safe and happy and healthy. I think probably in your case, I think connecting with a local person would be a good step. Which county did you say you're from?
Knox County.
Knox.
Hey, Matt. Hi, I'm
Yeah.
Heather Leffler. I'm also a cross-system regional liaison, and I'm actually assigned to Knox County. Is your family member an adult or a child?
Yes, they're living and working in the community. And, well, they're trying to live and work in the community.
They're an adult.
That way.
Okay.
I
Corey, can you help get us connected? I don't know if there's, because I'd like to reach out to Rhonda. Rhonda, would that be okay if I reach out to you after?
That would be great.
Yeah, I mean, we're just at a loss. We're stumped.
Okay.
This is the gold standard for Asperger's. And we're being
Yeah,
told.
I'll be happy to get you guys connected. That's not a problem at all. Heather, I'll make sure you can get connected with them and you guys can continue the conversation.
Okay.
Perfect. Thank you so
Thanks,
much.
Rhonda. You're certainly welcome.
Thanks, Matt and Heather.
There are other families who have any questions or things they're hearing or seeing that they would want to share on a larger basis?
I turned the computer off. I thought I was turning. Let me mute me.
I'm not seeing anything in the chat or hearing anything from other families.
It sounds like at the beginning, you went through all the updates that are going to happen this morning, or I guess it's this afternoon now, isn't it? So sounds like you guys have a great lineup this afternoon, and know that I'm here, and you can always reach me through Corey. And if there's any support that we can help with. I will, mention, I hope all of you know about our technical assistance teams. Matt and Heather, spoke up earlier today, and I think I saw Keith Banner is on as well. So, at the department, we have several different, Nyoka, I think I might have seen. Again, I'm driving, so I'm trying not to look at my phone. But the department has several different technical assistance teams that I hope that you all know about and are connected with. And I will just leave you with that, and have a great afternoon.
Thank you very much, Director Hauk. We appreciate it. We appreciate you taking the time to join us for a little bit here while you're on the road. Thank you very much.
Of course, thanks.
So with that, I'm going to go ahead and go into our presentations and some of our updates now from the department. We're excited to provide these to all of you. The first we're going to start with is a presentation from Heather and Matt, who we've been grateful to hear from so far today, who are going to share some about behavior supports. Heather and Matt, I'll be happy to turn it over to you.
Okay, thank you, Corey. Can you guys see my screen? All right. Well, we're going to talk about behavioral support strategies with restrictive measures. We updated our rule, and it's going into effect October 1st of this year. I'm Heather Leffler. I'm a cross-system regional liaison in the East Central area of the state, and I'm also lead for behavior supports for DODD. Matt?
I'm Matt Bevlinka. I'm Heather's counterpart to the West Central part of the state, and I work out of Dayton.
Anyone hear you?
I'm sorry? Okay, well, this rule makes us look at how we support people with behavioral support strategies, and sometimes we have to use restrictive measures. So what is a restrictive measure? It's a method of last resort that can be used by persons or entities who provide specialized services only when necessary to keep people healthy and safe, and it also has to be approved by the Human Rights Committee. So that's in a nutshell what a restrictive measure is. So when are restrictive measures included? We can do restrictive measures when there is a direct and serious risk of harm, or when there is a likelihood of legal sanction. Earlier, when Rhonda was talking about her family member, we could do restrictive measures if there was a situation where the person receiving specialized services, the person with IDD, is engaging in behaviors that put them at risk or someone else at risk when it comes to harm. So, of course, we're going to take steps to make sure that people are free from harm. That would be the person as well as others. And we'll give some examples in a minute. I'm going to get a little bit further along. So risk of harm, what are we talking about? Not only does it have to be a direct and serious risk of harm to self and others, but the person also has to be capable of causing physical harm. Or, the person may be causing physical harm, or it's very likely to begin to cause physical harm. Matt, do you have any examples of anything with that you'd like to share? I don't mean to put you on the spot, but you always have great examples. You don't have to if you don't want to. Matt and I are going to kind of tag team.
Sure. So I always think a real common one that we get from families and from teams is like dietary type restrictions. And I'm speaking just for myself. My wife tries to put dietary restrictions on me, and I'm sure if I, talked with my physician, I'm sure I could lose a few pounds, and there'd be recommendations that I drink less soda or whatever, and those are real common for the people that we work with. But drinking 4 Cokes a day probably isn't going to cause physical harm. So it doesn't meet that need where we can restrict somebody's access if they're able to purchase those items for themselves. And, there aren't other medical needs like diabetes or other things that, might fall under this category.
That's a great example, Matt. And that doesn't mean that we wouldn't try to educate the person and getting really creative with how we present information. Just about the facts about drinking, 4 Cokes a day probably isn't going to help you in the long run, but we all make choices. So please know that, we're going to continue that education to help the person understand the consequences of their choices. Another area is likelihood of legal sanction. That could be eviction, arrest, or incarceration. So an example would be a young lady meets a person. They become boyfriend, girlfriend. Her boyfriend doesn't have a lot of money. He's in between jobs right now. And so she wants to give some of her paycheck to the boyfriend, which, it could be okay, possibly. But if she's giving him sums of money that are going to cause her to not have money to pay her rent, then, we're looking at possible eviction. Now, if her paychecks are only, I don't know, if they're a much lower amount and she's giving some of that money to her boyfriend and it's not going to impact paying her rent, then that would not meet the criteria of likelihood of legal sanction. Moving on. So we're going to go into the types of restrictive measures. The first one that we're going to talk about is manual restraint. Manual restraint, say somebody is starting to get aggressive and starting to act out. They're struggling. It's time for a transition. And despite, everyone's efforts to prime that person and use visual supports, maybe sometimes they really just struggle. And so maybe they act out with physical aggression by hitting like the staff person. In a manual restraint would be to, block the person and give them some support, some hands-on support. But that has to stop once the risk of harm has passed. When the person stops hitting you and they are calm, whatever that looks like for that person, and that would be identified in the plan. The restraint stops immediately. Manual restraint also includes disabling or holding a wheelchair or other mobility device. And a manual restraint does not include a method that is routinely used during a medical procedure for patients without developmental disabilities. Sometimes we've seen practices where people during dental procedures might be, put on a board with straps, and that typically does not happen to people without developmental disabilities, just to give you an example. The next area is chemical restraint. This part of the rule has changed. So this is definitely an area that has changed. So we are looking at medication for the purpose of causing general or non-specific blunt suppression of behavior. So what we're really looking at now is how is the medication causing a marked difference in a person's ability to complete daily living activities. We don't think we're going to see this very often. And we've also given a window of 30 days because sometimes when psychotropic medications are being changed, there is a time of adjustment period for the body. So we did put in 30 days for that need. We'll get into if it is blunt suppression here in a minute on the next slide. Also with chemical restraint, any medications that is treating sexual offending behavior is a chemical restraint. Chemical restraints can also be utilized when risk of harm or precisely defined pattern of behavior that is very likely to result in risk of harm. That was new language that was added to this rule. Also want to point out chemical restraint does not include medications routinely prescribed with medical procedures like those pre-meds like Ativan before a dental appointment. That's a pretty common thing that happens for people without developmental disabilities. So of course, people would be able to get this medication as well. So as far as blunt suppression, the rule update talks about if you see somebody that has had a marked difference in their ability to carry out activities of daily living. It could be anyone on the team. It could be a direct service professional. It could be a transportation driver. It could be a family member. Just reaching out to the QIDP or the SSA and just making sure that we're notifying the prescriber that this is the symptom that we are seeing, and being specific, the marked changes in the person's functioning abilities. The prescriber may adjust the medication, or the team may do other might approach it differently so that we're mitigating that impact on the person. Say they're taking Zyprexa for medication. Allergies, I'm sorry. They're taking Zyprexa and maybe they'll take it at night so it doesn't affect them as much if they're too sleepy to be able to function and carry out their activities. Does anybody have any questions about this? We're covering it kind of quickly. Okay, we're going to keep going then. Another type of restrictive measure is mechanical restraint. This is just a use of a device to control an identified action restricting someone's movement or their function. A lot of times you'll see extra devices on seatbelts to help people who may not who may be trying to exit the vehicle while on the freeway. So we want to make sure we're keeping them safe. And you might see they're called buckle bosses. There's a lot of different names for that. Maybe somebody is not making safe choices and they'll run out into the street unaware of what's going on. Or it's not that they're unaware, but they're just really distressed and they're trying to run out into the street. So the team may decide to use a gait belt to help with that, and that would definitely be a mechanical restraint. And the whole time teams are using these restrictive measures, we're trying to figure out how to reduce the use of these restrictive measures and help the person live their best possible life. Just want to emphasize that as much as possible. And then the last type of restrictive measure is rights restrictions. And again, we can only use these when there is a likelihood of legal sanction, eviction, incarceration, or eviction. Oh, one more, timeout. We don't see timeout very often. Timeout is when you confine a person to a room or an area and you prevent that person from leaving that area. We are not talking about when a person says, hey, I need to take a break. I need to go over to this quiet area just so I can, calm and collect myself. As long as the person is controlling when they get to resume their other activities, their regular schedule, that is not timeout at all. That is just somebody taking a break. And we want to make sure that we offer up those opportunities as much as possible for people. So that's not what we're talking about. We're talking about when Johnny goes into the room and staff are like, you're not calm yet. We're not, and they block him from leaving the room. That is timeout. Again, this shall immediately stop if the person is engaging in self-abuse, becomes incontinent, or shows other signs of illness. Timeout is also limited to 30 minutes per incident and 1 hour in a 24-hour period. That's the last type of restrictive measure. Matt, take it away.
So these next few slides really just kind of speak to the philosophy behind the behavior support rule, and really just, I guess, the philosophy that we have as a department. And that's about supporting and caring in a responsive manner that promotes dignity, respect, and trust, and treating people as equal citizens. And so mentions on here, again, restrictive measures are only used when necessary to keep people safe, that they have to be temporary in nature. That one line in there that talks about promoting dignity, respect, and trust. I always think of a gentleman that I used to work with, who I will call John, I remember working with him. He had wanted to wear women's undergarments to his workshop outside of his clothing. And we as a team trying to protect his dignity, like, if you feel that strongly about it, nobody's going to force you away from that. Although, maybe 10 years ago his team might have. But we try to come up with a creative solution to meet that need. So we found we got him some silk boxers that he could wear under his clothes where he would feel the silk on it. We got him a silk robe he could wear around the house, and he was happy with that. It met the need, and it also protected his dignity when he was at work too. So that was just kind of an example of being able to meet his needs creatively. You can go to the next one, Heather. I don't think I can.
I gotcha.
It again to the philosophy of the department, enhancing quality of life, understanding and respecting a person's needs, expanding opportunities to communicate and exercise choice. So a lot of times, even when a restrictive measure is needed and it gets put in place, there's space there to still offer the person choice and allow them to express themselves. So going back to the example of somebody with like a restrictive diet. It seems the last month or so we've been getting some cases for Prader-Willi syndrome, which is a rare medical condition that oftentimes requires some kinds of restrictions to be put in place. But even within that, restricting someone's diet, you can still give them the opportunity to create the menu, go shopping if that's something that they can do, and choice within, day to day. So still recognizing that even if a restriction is needed, there's opportunity there. This just kind of continues with that, looking for positive measures. So, what are ways that we can limit the impact of restriction? Can we meet the need of keeping the person safe with, something less restrictive or a positive intervention? Finding alternative ways for the person to communicate, and adjusting the environment that they're around. And then, looking at some of the underlying things like addressing sensory needs, if there's an occupational therapist that might need to be involved, adjusting schedules and building trust. I think, yep. And so this is a slide here about trauma-informed care, and that should really be that perspective should really be incorporated into all aspects of a person's plan. So recognizing that people who have developmental disabilities are at much higher risk of being exposed to trauma, in addition to just the trauma of having a disability and having, maybe people that are involved in your life that need to help you showering or in the bathroom and those, kind of intimate moments. That in and of itself can be a trauma. So recognizing that we need to build any kind of restrictive measure that we put in place. We got to promote healing, recovery, resilience, and build on strengths. And then the bottom section there says teams need to understand and consider the why of behavior and continue to work to best serve the person. So why does the person have, an aversion to this activity, or why is the person, seeking to elope or whatever. And then, that should guide our discussions and building plans.
Thanks, Matt. So this slide just kind of goes through the process for implementing a restrictive measure. It starts off with the assessment, and the assessment has to be current within the past 12 months, and it will identify the risk of harm completed by people who meet the requirements of the rule. Also, sometimes I've seen where this piece can get a little tricky for families who may not have had services and then they're starting services, and maybe natural supports. I mean, natural supports don't document how many times Johnny hits his head when he's upset. So it's really important that teams are working together and really assessing how that individual needs to be supported. Sometimes we pull in school information, sometimes we pull in documentation from ABA therapists as well, and it's just really important that we're holistic with that assessment. Sometimes that includes also getting a risk assessment for someone who has maybe violent behavior and maybe they've been involved with the courts. It's really important that we get those risk assessments done to show the level the probability that this will happen again. And then the team uses that information to develop those strategies. And they're, developing those strategies. And that's the whole team coming together. It's really important that everyone's perspective, knowledge is valued and part of the development, especially with families. We're always excited when families are involved because you know your people really well, your family members really, really well, and sometimes those transitions, we rely heavily on you for all of that information, especially how people communicate when they communicate without using words. They communicate for sure. So we just need to make sure that we're tapping into all the knowledge. Informed consent is also a part of the process for restrictive measures. That's really important. If the team cannot get informed consent from the person or the guardian, then the process stops, and the team comes together to figure out alternatives, and they work through that using team process. Sometimes people in positions like Matt and me, we will get involved sometimes to help the teams, reframe, try to come up with alternatives. It's very interesting work, and everybody is so unique that each time we do this work, it is very different, and it should be meeting the needs of the person. If we get informed consent, then we move on to human rights approval of that restrictive measure, and their focus is just making sure that the restrictive measure met the requirements of the rule. And there's been some changes with HRC. We've done some family enhancements, and it's the last slide, and we'll get into the weeds or get into more detail about that in a few moments. And then RMN, that's the restrictive measure notification database at the state. We track all of the restrictive measures that are occurring throughout the state, and we do analysis, and it's really quite fascinating. We publish an annual report, and we help all the counties and ICE intermediate care facilities with their reporting as well. And then after the RMN is submitted, then staff are trained on the restrictive measures, and then they are able to implement the restrictive measure, and then the team will review that restrictive measure every 90 days. A couple of other enhancements that we made to the rule that you would be interested in as family members. There are notifications to the guardian when manual, chemical, or timeout restrictive measures are used. It will be discussed prior to the implementation of those restrictive measures if they want to be notified and how they want to be notified every time that is implemented. Also, with the 90-day reviews, we've enhanced the language to include more emphasis on getting input from the person receiving services and their guardian, just how things are going overall, holistically. Are these restrictive measures really helping you to make progress, and how is that going? So that's the restrictive measure process in a nutshell. Team process is really important with restrictive measures. When we're considering restrictive measures, it's the last resort, and this should not be easy for teams. I know that sometimes when people have very significant challenges and put themselves in harm's way, those decisions really aren't that difficult because we know that we have to keep the person free from harm. And so we're able to implement those. But as Matt said, restrictive measures are temporary in nature, so we're really trying to reduce the use of that. And what else can we do to support this person better? And how do we, are there any stones unturned? And how can we just support them better? That work never stops. Now, obviously, there are, some diagnoses where, the likelihood of reducing restrictive measures, Matt brought up Prader-Willi syndrome as one, that is a very serious condition that could result in death. So, reducing those restrictive measures looks very different. And not that we aren't reducing them, but it's going to look much smaller steps, almost minuscule steps, because we have to keep people safe. So again, it just depends on the person and the situation. The person and guardian has a right to refuse medication, treatment, or behavioral interventions, restrictive measures. And as I said, if a person does refuse, then, the county board of DD or the intermediate care facility has to present alternatives. And we meet as a state, we have what's called behavioral support workshops, and teams are able to come and learn from their colleagues. We at DODD attend them as well. And when teams get stuck and they don't know what else to do, they can bring their situations to those workshops and get lots of feedback, input. There's lots of people who are dealing with very similar situations in terms of frequency and intensity. So, I mean, they're really, I don't know, it's been a wonderful experience just watching the state of Ohio grow through those workshops and really getting support from their colleagues in the state to serve people better. And again, alternatives should focus on finding options that are important to the person, really finding what motivates them, what makes them happy, what makes their heart sing with joy, and how can we build that in to, their every single day for them. Matt, did you want to cover this? I think I might have covered a slide too. Sorry.
Oh, you're good. Sure, I'll take a stab at it. So guardian requested restrictions. So first, nothing would prevent a guardian from making requests, and it's great when we work with people who have very involved guardians who attend team meetings and have a person's best interests in mind. Um, the professionals on the team, the SSAs and the Qs, can let the guardians know where there's conflict and what the request is and what we're allowed to do in terms of federal Medicaid guidelines and our behavior support rule. Um, Requests are brought to the team, and then the team can determine whether a risk of harm or likelihood of legal sanction is there. And then if those criteria are met, then a rights restriction can be put in place. The team and especially the SSA look for alternative ways to meet and mitigate concerns. Um, so I would throw out as an example, a real common one that we see is locks on doors. So in the past, if you were working with someone um, who, elopement's a concern, we could deadbolt the front door and then the problem's solved and, the person can't get out of the house. But really what we want to look for is why is the person trying to leave and why is it an issue? Can we teach pedestrian safety skills? Can we have the individual go and request staff to accompany them outside if that's needed? Can the person be alone in the community for certain periods of time? And if not, we need to look at that lock as a restrictive measure. Um, but I find a lot of times that restrictions like locks are put in place for our own comfort or for the convenience of staff so that they can, be in other parts of the house and not have to watch the living room or the front door. And that need can be oftentimes met in other ways. So if we put a chime on the front door that when, Johnny's going out the front door, it alerts the staff that the door is open. Can we keep the person safe that way? And we never want to look at we never want to remove a restrictive measure that's needed and put someone in an unsafe situation. But if we can keep the person safe and meet the need without putting locks on everything, then I think that's best for everyone. Was I going to do this one, Heather?
I think so.
Okay, we'll give it a try. Doctor's orders, recommendations, doctor's orders for restrictive measures. Um, we like to look at a doctor, physician, psychiatrist as being a member of the team who can provide recommendations. So sometimes doctors will have orders, person needs to be on a caffeine-free diet or something like that. And there's really not a risk of harm there that we could enforce through through a restrictive measure. Um, so the doctor's bringing that concern forward and it's worth exploring. Can we limit caffeine? Can we, if the person likes to drink Mountain Dew all day, can we get caffeine-free Mountain Dew, or can we look at other options that the person chooses, but still meets the recommendation that the doctor is making? But that said, at the end of the day, if there's no significant risk of legal harm or uh, health and safety or legal sanction, we're not going to be able to restrict something like that. So an important recommendation, but we still need to respect a person's rights. And the rest of the slide kind of just enumerates that.
Thanks, Matt. We do
Mhm.
see this, and people with DD as well. I mean, as everyone, you do have choices throughout your day. Again, we're trying to offer education and being really creative with that education and what that looks like. Some people will take information from most people will take information from a few select individuals, but then there are usually some people that we struggle to take information from. So how can we capitalize on relationships then to explain the risks with the choice making? So it's definitely a lot of work for sure, just to support people to be their best version of themselves. Here we go. Here is the Human Rights Committee. They do the approval of the restrictive measures, making sure that they meet the requirements of the rule. Previously, we didn't have some of these new, we didn't have this in the rules. So now there has to be notice to the guardian or the person 72 hours prior to the meeting where they're going to be reviewing the restrictive measure. Um, that's so that the guardian or the person is able to attend the meeting if they choose. Now, they would only be able to attend the portion of the meeting for their family member or themselves. They wouldn't be able to attend the entire meeting. That would break confidentiality. Um, Also, the guardian or the person has the right to present information. I gave you an example earlier in the presentation, when people are starting to receive services in their family home, or maybe they've moved out of the family home and they're living in the community. Sometimes there's never been paid supports, and so we don't have a lot of documentation about the person's needs. And it's really critical that we allow not allow, but guardian individual has the right to present information. We're really excited about this part of the rule because it wasn't in place before. And then when Human Rights Committee makes their determination, they share that with the individual or the person, and they're able to request reconsideration of that rejection. And they're able to put forth additional information for the rationale for the restrictive measure to the SSA or the QIDP within 14 days of that notification. And then from there, Human Rights Committee will consider the request for consideration and respond within 14 days. So again, these are just enhancements to give families appeal process with human rights committees, as well as the ability to present information. We did have some counties that were doing this already, and it was going very, very well. So we just formalized it and put it in the rule. And again, we hope that you've heard there are no blanket answers. Every situation is looked at individually based on that person's needs, wishes, the team discussions, and it's very, very individualized. So you will see there are no blanket answers in every one of our presentations, no matter who we are presenting to, because it is true. I've been doing this work since 2015, and there are no blanket answers. Matt, is there anything else you want to add?
I don't think so. I would just again like to stress that to speak up, advocate for the people that you care for, and attend HRC meetings. And if there are things that you want added in the plan, let your SSA or your Q know. Restrictive measures in and of themselves aren't good or bad things. We just need to ensure that if they're in place, they're being used appropriately and they're in place because they're needed. So I always like to throw that out. I think there's a lot of attention paid to restrictive measures because it is important to monitor how people are restricting rights, but it's not a good or a bad thing. It's if somebody needs it, we put it in place and we follow the protocol.
Exactly. Well said, Matt. Are there any questions? All right. Well, that
I am
concludes our
not hearing
presentation.
any or seeing any in the chat. So Heather and Matt, thank you very much for this information about restrictive measures and behavioral support. We really appreciate the time today. If anybody does have any questions or wants to learn more, you're welcome to connect with us, and we're happy to get you connected for more information. So Matt and Heather, thank you again.
Thank you.
Moving on in our presentation today, in a previous conversation, we've had families and other partners suggest that we have folks from Ohio Rise join us as well to provide brief updates and answer any questions. And I'm really happy to share that. I believe we have Kelly here as well as Autumn, who can provide a brief update about Ohio Rise and what's happening in that space, and perhaps answer one or two questions as
my PowerPoint slides.
great. Thank you.
Can everyone see them? And I can't see anyone on the screen now, so just give me a thumbs up or
Yes, we can see them.
We
Thanks.
can
or
see
let
them.
me
Thank
know
you so
if you can
much.
see the slides. All right. So actually, Autumn is here with us today, and she's going to be on just to answer any questions that you all may have. And then I am actually presenting with Chris, my colleague at the Department of Medicaid. So I'm our External Affairs Administrator, which basically just means I do communications and stakeholder engagement work. Chris, do you want to introduce yourself?
Sure. Give me just a second here. Let me get my camera on. Hi, everybody. My name is Chris Candelo. Some folks who may have been with DODD for several years may know me better as Chris Miller, but that was my maiden name. My married name is Candelo, and I will be picking up the second half of the presentation. Thank you.
And Autumn, do you want to introduce yourself as well?
I sure can. Hi, I'm Autumn Darnell with the Ohio Rise Policy and Program Development Team, and here to support Chris and Kelly with the presentation. I had an appointment, so I thought I wasn't going to make it back in time to do the presentation. So Chris is filling in for me, so I appreciate that.
Thanks, Autumn and Chris. All right, I'm going to go ahead and get us started. So Ohio Rise, many of you must be familiar with it since you did request us to start joining these meetings and provide brief updates with you all as the program is implemented. So the RISE in Ohio Rise stands for Resilience Through Integrated Services and Excellence, because we're really trying to help youth and families that are a part of multiple systems be better integrated across the state agencies and at their local entities that they're being served by. And so Ohio Rise has a number of objectives, and the one of the main goals of the program is to serve kids with complex behavioral health and multi-system needs. And the program launched on July 1st, so we're almost 100 days in. Um, And so I'll start with our first objective. It's really about trying to prevent custody relinquishment, because we've all heard of stories where families are experiencing access issues to costly behavioral health care treatment services, like, for example, residential treatment services. And so we want to try to keep families together and better serve our multi-system youth. And how are we going to do that? Well, we want to make sure that we're providing more intensive in-home and community-based services that are now being offered through the Ohio Rise program, as well as supports. And when I think about supports for the program, I'm thinking of care coordination in particular. And so this care coordination is a key component of Ohio Rise, and it will use a national model called high fidelity wraparound approaches in the care coordination that really puts families and youth at the center of the care coordination and their treatment services. And it prioritizes their voice and their choice so that they stay more engaged in their treatment and connecting to other supports in the community. Another objective is for our stakeholders. So we've worked really closely over the past couple of years with stakeholders to design and develop the Ohio Rise program. We've invited stakeholders from all across the state, people with lived experience, people who are part of other systems, so the developmental disability system, the court system, child protection system, behavioral health care system, education system. We have a lot of folks that come together. We meet monthly. We've also had work groups to really build Ohio Rise from the ground up, since it's a start. And similarly, we're using a shared governance model. So our state sister agencies, like the Department of Developmental Disabilities, has really designed the program alongside us before we even launched it or introduced it to the stakeholders. And they continue to work with us on the implementation of the program. And again, it's the same concept where they already have programs and initiatives that they are building or that are in place. And we wanted to make sure Ohio Rise aligned with the programs and initiatives that they are working on and working towards. So who gets into Ohio Rise? Eligibility for Ohio Rise, children and youth have to meet certain criteria. They have to be Medicaid eligible. They can maintain their fee for service. They will maintain their fee for service and their managed care plan if they have a managed care plan. They're able to keep their existing 1915C waiver, so their intellectual developmental disability waiver, the Ohio home care waiver, etc. They have to be age 0 through 20 at the time of enrolling into Ohio Rise. And the key piece here is that they have to require significant and intensive behavioral health treatment needs. And this is all determined. The way to get into Ohio Rise is through a CANS assessment, or what's known as a child and adolescent needs and strengths assessment. So based on that assessment, it would be decided if the child could be eligible for the program. Or they might have an inpatient stay in a hospital for a mental illness or substance use disorder. Then they would be determined eligible if they also meet the Medicaid eligibility requirements. Or if they have an inpatient stay in a psychiatric residential treatment facility, or PRTF. So currently we do not have PRTFs in Ohio, but that will be something that's part of the program in 2023. And we do expect to enroll 50 to 60,000 youth by the end of the first year, so next July. So since we've launched on July 1st, we have over 1,500 CANS assessors. So that CANS assessors are those people that go out and do that eligibility assessment. The CANS assessors have submitted in our new CANS IT system over 6,500 assessments to determine eligibility, and then do ongoing care planning with those assessments as well. And so far, we've enrolled um, nearly 1,000 children and youth into the Ohio Rise program. And I am going to turn it over to Chris to talk about our Ohio Rise administrative code rules.
Okay, so just to kind of let you know, so the way that Ohio Rise works, there is the kind of like the general Ohio Rise program, which is what Kelly was mentioning before. And then there's also, we have a 1915C waiver. So I'm going to walk you through just super high level what the aspects of those are. But as you see in front of you, we have some rule references here. So the rules that pertain to the general Ohio Rise program, and it's the general Ohio Rise program where an individual who's currently enrolled in a 1915C waiver would keep, like a DODD 1915C waiver, IO level 1 or self, would be able to keep that 1915C waiver, and then if they met the Ohio Rise eligibility criteria, also access the Ohio Rise general program services. But as I mentioned, also then Ohio Rise has its own 1915C waiver, and the rules here associate with that. And we'll talk here a little bit about what's covered under that waiver. Again, just kind of high level. Next slide, please. Okay, so what you have in front of you is the scope of services covered under Ohio Rise. So going from the left-hand side, Ohio Rise covers existing behavioral health services with some limited exceptions. For example, behavioral health emergency departments. It covers mobile response stabilization service, otherwise known as MRSS, which is also covered by managed care organizations as well as fee-for-service. It covers something new that we have, which is moderate and intensive care, moderate and or actually intensive care coordination. There's actually two different types of care coordination that we are implementing with Ohio Rise. Ohio Rise also will cover the intensive home-based treatment service. It will, as Kelly mentioned, once we have it up and running, we'll cover the Psychiatric Residential Treatment Facility, or PRTF. There is a component in the General Ohio RISE program known as the 1915B3 services. You don't often hear them referred to as that way, but these are services that are available to anyone who's on the General Ohio RISE program, and those services are behavioral health respite and primary flex funds. Behavioral health respite is meant to be a respite to provide relief to the primary caregiver, specifically designed to address some of the behavioral health needs, could be provided inside the home as needed. And a lot of the providers associated with that are fairly open and flexible. And primary flex funds are at the $1,500 cap per year. And that is designed to decrease an individual's need for Medicaid or increase their assistance in the community. And then, as I mentioned, so we do have an Ohio RISE 1915C waiver. The unique services and eligibility to that. So the unique services are, it has out-of-home respite, which, as it sounds, is a respite service where the respite service is designed to be provided outside of the individual's home. It has a service that's known as Transitional Services and Supports, which is a service that's designed to assist an individual who's transitioning from, say, out of an institution into a community-based home, or from one home environment to a different home environment, to be able to provide the supports that's needed both for the individual and for the family that resides in that home. And it also has a secondary flex funds feature. So there's just the 3 services that are associated with the 1915C waiver. Just wanted to make that clear for folks. And next slide, please. A little bit more about the 1915C waiver that's associated with the Ohio RISE program. So it was developed to mitigate risks and prevent negative health and outcomes for children with serious emotional disturbances and functional limitations, with a focus on kids who are at risk for or already involved with the child protection system or juvenile justice system. It's really designed, as I know most of you probably already know, the 1915C waivers are always focusing on making sure that they prevent institutionalization, and that is what this waiver is designed to do as well. It's designed to prevent a child or a youth from going into an institution that would be otherwise treating their behavioral health needs. So the 1915C waiver provides waiver enrollees with additional services and supports that are not otherwise covered under the state plan. And one of the primary things to note about the waiver, and this is specific to the Ohio RISE 1915C waiver, this does not apply to the Ohio RISE general program. The 1915C waiver does also have a mandatory enrollment in managed care for those who are eligible in managed care. So if you have an individual who's looking to enroll on the Ohio RISE waiver, it will be a mandatory enrollment for them to be enrolled in managed care. Just wanted to let folks know that. The waiver itself does have a phase-in schedule for the first 12 months. The enrollment cap for the waiver for the first year is a total of 1,000 individuals. And then the cost cap for the waiver is $15,000 across the 365-day waiver span. Next slide, please. So on this slide, you have a nice little synopsis of the resources that we have available on our website to be able to answer some of the common questions that we found about Ohio RISE eligibility and enrollment. It shows you right there, we have a link on our page that talks about resources for members and families tile. We also have a little subset under that that talks about who may benefit from the Ohio RISE, and there's also questions contained then within that particular section that you can look at if you are interested in seeing what the frequently asked questions have been and the answers that have been provided. Next slide, please. Okay. And with that, we will open it up for questions.
Thank you very much for that presentation. We appreciate it. We may have time for one question or two. Do we have any questions from folks who are joining us today?
Yes, this is Autumn. I just saw that. I was just getting ready to say we'll send the slides over because there's actually active links in the slides, so you can get to the rules and the different areas. So yes, we'll send those over to you.
Yeah, thank you very much, Autumn. So that is one thing I forgot to share at the beginning of the conversation, is I will send an email out to everybody who registered for today's conversation, and in the email will have links and resources to a lot of what we're hearing in presentations today. So you will get that. I do see we have a question from Angie in the audience. Hi, Angie. Are you able to unmute?
Yeah. Yes. Can you wait? Me? I have a question about equipment.
She has a question about equipment and didn't know when to ask if the questions right now were just related to that presentation or whether it was in general.
So right now the questions are specific to this presentation.
Right, that's what we weren't sure if it was related or not. So
Okay.
we don't have a question about the presentation.
Sorry.
Well, thank you. Well, Kelly and Autumn, we really appreciate the presentations today, and thank you very much, Chris, for being here as well and sharing. So if you have any questions, we can get you connected with the Ohio Rise team. And again, thank you for being here today.
Thanks for having us.
Thank you.
Thank you.
So moving on now, I'm excited to introduce to you Keith Banner, who is going to join us and talk about what's happening with our adult day services. Maybe perhaps talking about technology first and employment first and the exciting things happening with him and his team. Thank you very much for being here, Keith.
Thank you, Corey. I don't know why I called you Chris. Sorry. Thank you, Corey. Hi, I'm Keith Banner, and I'm with the Ohio Department of Developmental Disabilities, and I do community life engagement. And basically, I'm the team lead for that, which includes technology first and employment first, two of our flagship initiatives. Can I share my screen? Is that okay? Cool.
Absolutely.
See if I've got what I need. Do y'all see my screen okay? Is it okay? Does somebody say yes, because I can't see anybody?
Yep, it's great.
Perfect, thank you. I get scared. It feels like you're in outside in outer space on Teams sometimes. But anyway, this is the Ohio Tech First page, and I wanted to show you. There's a lot of great stuff on it, but I wanted to hone in on this new development that we have. We have three new kind of goals around supportive technology from a report you can download here through the Technology First and the DSP Workforce Crisis. And basically, it's a 4-page, 8-page actually, document that walks through the data and the intent behind the report, which helped create these three goals and the indicators that I'm going to talk about. Basically, as a technology as a solution to help with the DSP recruitment and retention. And you can read this when you want to. But here's the three indicators I'm going to show real quickly. And you can go to this website, and I'll put the link in the chat after I get through. Basically, we have three indicators to kind of show us the goals that we're trying to go after to increase the likelihood of supportive tech and for folks who would benefit from it. And the first indicator is remote support services will increase 15% by June 30th. And this gives you a kind of a graphic of where we are now, where we are back in 2018, and then where we want to go to increase it by 15%, the use of it in the HCBS waivers. This is another indicator too. 18% of people who use residential support will use remote supports by 2026. This again gives you the background. As of July 31st, 2022, there are 1,476 people utilizing remote supports and 38,945 people reutilizing residential services on a Medicaid waiver. We want to increase that to 18% by 2026. This is a lofty goal because we're at 4% of that goal now, and this is 2026 is the target date. And then the third and last indicator is 25% of folks who utilize home and community-based waiver services will use technology or virtual supports by 2026. And again, this gives you the background info that we're at 70% of that 25% goal now. So by 2026, we want to get that up to 25%. This is the link. I'm going to share it in the chat for you all now. Like chewing and walking and chewing gum for me. I have to talk myself through this. I'm going to put that in the link, the link in the chat. There we go. So if you're interested, you can go to that site, and I'm going to go back and share one more thing, just because it has a bunch of information. I think it might be interesting to you guys. Hopefully, this is a Padlet I and other folks in my region kind of add to. And I can put this link in the chat too, and you'll have to listen to me walk my way through that as well. But anyway, we have a regular monthly community of practice. It's happening tomorrow, actually, so you're welcome to join if you want to. And the link and everything is on the Padlet here. But I wanted to walk us through a couple of great things that are happening in October. It's National Disability Employment Awareness Month, and this link takes you to more information around that, and has some really cool graphics. And here in Ohio, we're also celebrating the 10th anniversary of Employment First, so it's a big kind of October 2022 for us, and we will be pushing out some great stories around employment, people who have got really great jobs, who've programs that are doing really great innovative ways to help people learn about work. So be on the lookout for that, and you can look into all of that at that link. And then this resource is a training that's coming up, if it shows up. Yes, that's happening October 4th, called Putting It All Together, Developing Real World Relationships and Opportunities, where a lot of us, Britta Huff from my team, Jenna Allen from Ocali, Celia Schlomer from USAID, and I are going to walk folks through how to use some of the Charting the Life course tools to resource map the community, and then also to use the tools to kind of help figure out what people are interested in, and then kind of acting on that in really practical, real world, community-based ways. So you can go on that link on the Padlet, and you can click there to register if you're interested in that. And I'm gonna, like I said, I'm gonna put that link in the chat for you if you're interested to look at that later. Lots of good information on there. Am I going too long? Tell me to stop, because I got one more thing I can tell you about. Great. Okay, cool. We have 3 really cool grants that are being stood up around supportive tech as well. We have one for housing corporations to kind of look at how supportive tech could help the lives of people that are living in their housing, and that's coming out next week. We have an innovative tech solution RFP going out, I think, next week as well, which asks providers and other folks involved in the tech industry to kind of think about really unique, innovative ways to help people access and use supportive technology to do what they want to do and accomplish the things they want to accomplish and live the lives they want to live. So that's coming out next week. And then maybe in a few weeks, maybe a couple weeks, another one called around tech and residential providers, helping residential providers build capacity to learn about technology with access to subject matter experts that'll help them build plans and then implement them. So those 3 grants, please be on the lookout for those. And I wanted to end with the fact that I am the lead of the community life engagement team, but I've been doing kind of both roles. I'm down in Southwest Ohio. That's where I started my connection to it. So, but now we found a great replacement for me in Southwest, so I can kind of focus in on the team. And her name is Ann Tapia, and some of you might know she's going to be the Southwest Ohio Community Life Engagement Project Manager. She's now with the Southwest Ohio Regional Autism Advisory Council, but she's coming over at the end of October to be the project manager in Southwest Ohio. So I think that's my news. Thank you guys for listening to me.
Thank you very much for those updates, Keith, and introducing a new team member. We're excited about that. Do we have maybe 1 or 2 questions for Keith? If not, we'll move on to our next update. And thank you so much, Keith. We really appreciate you being here. I'm going to introduce to you to Beth Chambers, who is leading up our work with the Ohio ISP. She's going to provide kind of an overview of what's happening here. And Angie, I see your hand up, and I will make sure we get to you. So thanks for being here, Beth. We appreciate it.
Thank you. Do we want to get Angie's question, or do you want me to?
Oh, no, go right ahead.
Okay. All right, I'm going to share my screen. Welcome, everybody. Thanks for having me here today. I'm thrilled to be part of this. We're going to talk about the Ohio ISP, which is, as you may well know, work in progress. So I'm Beth Chambers. I work for the Ohio Department of Developmental Disabilities, and I'm the statewide Ohio ISP manager. I've put my contact information there. Feel free to reach out. Want to just share with you some highlights of what we're working on. First of all, just want to say it's happening, and that there are over 400 plans. I think there's 451 actually today. It keeps changing minute to minute, which is great. And when I say Ohio ISPs in the system, so some of those are in draft. Many of them are just kind of people playing around. Some are final. So we're really getting in there and checking out, reaching out to people to see where they are with this process. Many county boards and intermediate care facilities are currently using Ohio ISP. I see I have a typo there. Sorry about that. And that means they're using the paper template, getting familiar with the questions and the template and the process. And some are using the online system already. And we're, again, supporting people in what stage of the process they're at with that. And then Director Halk mentioned regional teams. The Ohio ISP team, we have groups of people who are actively supporting teams as they transition to Ohio ISP. We have regional support facilitators that are housed in each of the superintendent regions. They are kind of the face of the Ohio ISP. And not only that, we know there's a huge emphasis on Ohio ISP, but really reaching out to support those service and support administrators and QIDPs around the state to support them in their day-to-day operations. So we're meeting teams where they are. That can be the paper version, the online system, getting a plan together to transition to Ohio ISP. We really want people to take a step back and breathe and know that we're here for support. If people are like, okay, this is taking a long time, we'll get to that later, like some of the feedback we're hearing, but just asking people to take a breath, take a look at this, approach things a new way, and really just know that we are going to get there. People have done it. We're hearing some success stories, and break it down into manageable chunks for people. So that's what we're trying to do right now. The online system, there's a little bit, I don't want to go too far in the weeds with this today, but there's DODD Salesforce system, and that is a platform. It's like the source of truth where things can be directly entered into that system, or there can be third-party vendors. And right now we have Britco or Primary Solutions, PSI, who are using their online platforms that county boards and ICFs might be currently using for other sources as well. So they might be already doing some things in their system. So we've given the opportunity for those vendors to have the same standardized question, that use the same process. It's still a standardized system, but what they do is capture it in their system, and then it transfers over into Salesforce, the DODD system. So again, I don't want to get too in the weeds in that today, but we want to let everyone know that any entity can use Salesforce and access what they need through that system. So we'll have more to come on that, more detail, but I just wanted people to know that that's one of the things that's in the works. And then really want to go back to revisiting the why of Ohio ISP. We heard that we had town halls, we have family forums, we had a lot of ways to get feedback from people. The key principles were standardization, simplification, portability, And the focus centered, that although we're using a standardized set of questions and a planning process, reason is to capture that personal information and to tell each individual personal story. So we feel that both can be done at the same time. As I said, it's a work in progress. Simplification, so that we are taking complex information, sometimes from very clinical experts, and synthesizing that in a way that the person and their family and their team can make sense of that, the person implementing it, so that we're really clear on what the person needs and wants and how we're all going to help them get there. Portability, that's important. We have 88 county boards and over 400 ICFs that we're doing planning in various ways. So we want this to be standardized so that if a person moves from one county to another, from one agency to another, that things are very similar. There's the same planning process. There's the same basic questions, and the content is the same, so that we're all on the same page and we can focus on more interesting things. And then feedback. We certainly value your feedback. Like I said, I'm humbled to present and to be talking with this group. We have to do our due diligence and make sure that we get this right, and that we keep evaluating and monitoring and listening all the way through and supporting. So we do value the feedback. We're currently analyzing feedback that we have to date. And we have training and support teams dealing with some of the big pain points right now: length of plans, the time it takes to do assessments, really working with entities to help balance what people already know about people, and how do we get to know it another layer? How do we dig a little deeper? How do we respect the process and doing things a new way, and then balance that with being respectful of people's time, and making sure that we're not trying to tackle everything in one day, that we're coming back to this and really keep getting to know people and keep asking questions, and that we're doing it in the most effective and efficient way, that we're familiarizing everyone's familiarizing themselves with the questions and the content prior to ever meeting with people and families, that kind of thing. And then enhancements. We heard you. We know that it's not perfect. We know that there are many places we can enhance this and move forward, make improvements. We will continue to listen and support you. We will provide lots of different ways for you to give feedback. Right now, at the end of the presentation, there's an Ohio ISP email address that is checked daily, a couple times a day, and that will get you to the point you need where we can respond. We're looking at frequently asked questions. We're constantly trying to evaluate and analyze the feedback we're getting to see how we can better enhance that. We're working with our IT partners if it involves the online solution, the platforms. Some of the enhancements that are currently being worked on: character limit increases. We've heard from SSAs and Qs that there's not enough the template doesn't allow us enough characters or spaces, all of those things, to actually put the pertinent information, especially if someone has some complex needs. So we are working to get that done right now. That will be a pretty quick turnaround to allow plan authors to add as much detail as they need to, and not be kind of limited in that. Collaborating and focusing on ways to support people and families, complex needs, both medical and behavioral. We are looking at that. I know Corey and I have some time scheduled. We're going to meet regularly to really see how we can get at this, not just through the template, through approaching things differently, using the template, the planning process, to really hear from people, to see what we can do to better support those cases where we don't feel like this template is getting at what people feel is needed. So really kind of listening and understanding that better, and then getting some samples and some examples ready, trying to look at, okay, what's the most complex situation we've seen right now? How can we gauge that against what we've currently got in place? How do we then get together with all entities to make sure that we're capturing what we need to and moving forward? So that is top on our priority list and our radar. And then I just have a contact us. There's the email address I was talking about, and there's also our website. That's all I have. I'll open it up for questions.
Yeah, thank you very much for that presentation, Beth. We really appreciate the overview and the update of what's happening with the Ohio ISP. I do see somebody with the name of Christine has their hand raised. Christine, did you have a question today?
It's coming through as Angie. It should be coming through as Angie.
Okay.
Not sure why it switched.
So I see two hands. I see a hand for Angie and a hand for Christine, but so
using the same
okay.
screen, so I'm not really sure how that happened.
No worries. Thanks for letting me know. I appreciate it. Do you guys have a question specific to the Ohio ISP?
No.
No.
No? Okay. Well, Beth, we really appreciate your updates and sharing that information with us today. And I will share resources out with everybody about the Ohio ISP and some other opportunities for information as well, and the email that goes out to the folks who have registered for today.
Thanks, everyone. Appreciate the opportunity. It's great seeing everyone today.
Thanks again, Beth. So I am going to go into a really quick family update here real quick, and then we'll open it up to general questions. Give me a second here to catch up with my PowerPoint. I apologize. So for Meredith Mendoza has joined us here at the department, and she is our Family Outreach and Education Coordinator. She is also with us here today. Meredith, I wasn't sure if you wanted to take a moment to say hello.
Hi, thanks everybody, and I'm looking forward to joining you in the future.
So thank you very much for being here, Meredith. And Meredith is here to help provide resources and information to families. She will be coordinating our Family Advisory Council in 2023. So we were really excited to have her as part of our team, and she's happy to be a resource and a connection for all of you as well. Some different things we have going on with the department is we do have a trauma sensitive mindfulness programming that is specific to families. This is with collaboration with Soulbird Consulting, and it's really a support that we are providing families who are supporting people with developmental disabilities. It's a 6 weeks course that starts in October, and there are a couple of different opportunities, I think, to join. There's a couple of different program offerings that they are offering as well. If you want to learn more about the trauma-sensitive mindfulness programming, you can visit soulbirdconsulting.info/events and learn more information and get registered there. In addition to that, we also have forthcoming a program called Families at the Center of Connected Communities. We do not have the dates finalized just yet, but in November, we will be working with families to help them identify tools and techniques to build social network and collaborations that they could use for support and in building community. So we are looking forward to that opportunity in November, and I will distribute that information as soon as I have it. We always continue to rely on our Family Resource Network of Ohio, frnoohio.org, and you can find a multitude of resources and information here. They have a video link where you can find information about charting the life course, and then there are life course specific videos there as well that are resources. I'll also share it. It has an events calendar where a variety of different resources and programs and presentations are listed for families to look at and decide which ones they think they would like to participate in and register for. So again, all of those are at the Family Resource Network of Ohio. Also, you can always subscribe to our different communications and publications that come out from the department. In a forthcoming email, I'll put the link in there. But this is where you can get our family connection that we send out every month with updates and news of things happening within the department as well as within Ohio, and serving families of people with developmental disabilities. I know we're really short on time here, and I do want to take an opportunity to allow Angie to share her question with us today.
I just and as been about technology. I am wondering whether 24-hour waiver, but I also need some tech and tech now. Tech, I can technology like a door opener and cell phones. They are trying to tell me the fact against them from waiver. Like our because I don't think I don't think that the fair to anybody. Like, I don't know what to do. I don't know who to ask.
So I understand, do you have a question about a waiver and what can be covered by a waiver? Am I understanding you correctly?
I know. I know I am hard to understand. Yes, I'm asking what is covered by the and by technology is changing our cause
Want me to help? She's asking some adaptive equipment and technology was submitted. It was subsequently denied because they said she would need to decrease her hours. And she, as you can tell, she has athetoid cerebral palsy and such. And she needs the person here. Not only is she having some medical complications as far as potential seizures and such, but she needs to be transferred on and off the toilet. You never know when nature's going to call for feeding, transfers. She has a lot of multiple physical needs, but she still wants to be able to do things on her own independently, without the caregiver needing to keep asking the caregiver. Because as you can tell too, she has a hard time speaking. So she has to try to get her point across to the caregiver what she's even asking. And so automatic door openers and a mobile phone was requested. And the interpretation of the county was that she needed to decrease her paid staff hours, of which is not feasible. But she still wants to be able to do things on her own and not go through all the struggle, you know, of asking another person and feeling sort of like, you know, she's not doing it herself, and also the struggle of trying to get her point across to the other person. So she needs the adaptive equipment to be able to do that, but she can't go without the hours of a physical person here to be able to support her.
Yeah.
Right. No, I really appreciate that question, Angie. How about this? How about we conclude here, and if you can sit tight, I'll get some contact information from you so that we can follow up and help you. Would that sound good?
Okay.
Great.
Mhm.
Well, we
Thank
are at, oh, you're welcome. We are at 1:30. I do want to respect everybody's time. We appreciate you being here with us today and getting these updates and sharing your questions and feedback with us. Our next Family Advisory Council meeting is going to be December the 14th. And that is when we will meet again. My contact information is there. So again, we do thank everybody for being here, and we look forward to seeing you in December. And Angie, sit tight, and I will follow up with you. Thanks again, everybody, for being here.
Thanks.